Hello. First of all, thanks. Well, my name is Alex. I'm a researcher in the Department of Psychiatry at the University of Oxford. I work in a group, called NeuroSet, which you can see at the top left there. And we're a group of interdisciplinary researchers. We all work in an interdisciplinary way. We're all broadly interested in, well, as you can see, the relation between the ethical implications of research in neuroscience and psychiatry. As I say, we've all got our different, sort of slightly different orientations. Mine's primarily philosophical, and I'm reporting on one of the deliverables of work package 8 of Roadmap, which we've just recently we've submitted for peer review, which is, broadly speaking, an ethics paper. So I'd like to thank Chris for inviting me to take part in this session, because it's been great working with Chris, and also I'd like to thank Susanna and also the Edinburgh team for Work Package 2, because they've all contributed to the writing of this paper and made it the good piece of work that it is. Okay, so so I'm going to summarise this paper that we've written, which, as I say, was one of the deliverables. So we started working on it around a year ago, and we submitted it within the Roadmap Consortium at the beginning of September, and then we've just adapted it slightly and submitted it for peer review, and it focuses. Well, I mean, I'm going to focus in what you'll see on three particular sets of findings within it that I think sort of are particularly pertinent with respect to questions about the use of real-world data and real-world evidence. So this is the title of the paper. I mean, this is health outcome prioritisation in Alzheimer's disease, understanding the ethical landscape. So. As you might expect, the aim was to take a kind of bird's eye view of what ethical considerations come to bear when we think about how to prioritise outcomes. The aim is to understand and enumerate the considerations that are relevant for achieving a fair and a just prioritisation of health outcomes in Alzheimer's disease. The paper is semi-systematic in the sense that well, there were two stages. There was a systematic stage of the kind you'd expect in a systematic review, and then there was a second stage. And in the first stage, we decided on our inclusion criteria, and after full text review, we arrived at I think it was 56 papers which were suitable for inclusion. And then over the course of the year, writing the paper amongst the team, there was the second phase of snowball sampling and contributions from the rest of the team, which resulted in 129 documents that were used. Our analysis suggested that there are 9 key areas of ethical relevance, which I'll go through in a second. And we think that these could be also grouped into three sort of subcategories pertaining to some methodological concerns. So these are the 9 themes of relevance, and as you'll see, the ones that I highlighted in green are the ones that I'm going to go into in some more detail, because they relate most specifically to the use of real-world data and real-world evidence. Okay, so the first is quite a high-level concern, I suppose, but the first ethical concern was public health and distributive justice. So this, broadly speaking, is the tension between individual and societal benefits in approaches to Alzheimer's disease treatment. So how you weigh up the benefits, the importance or the value of the benefits to individuals and to kind of population-level goals. The second theme was related to the scarcity of resources. So, I mean, just to sort of state it baldly, to prioritise is inevitably to say no to somebody. I mean, this is a quote from one of the papers we found, and this is because resources are finite. So, in deciding how we allocate resources, we're going to need to rank them in some kind of hierarchy, and this means that we need to scrutinise the adequacy of the reasons for allocating resources one way or the other. The third theme of relevance was the heterogeneity of Alzheimer's disease as a disease and as people affected by it, and the changes in their circumstances and the way that the disease changes over the course, the life course. And this is important because the availability of resources changes, and because Alzheimer's disease is a heterogeneous condition, what might be important to do at different times also changes, and what we might want to prioritise at different times also changes. The fourth is gaps in knowledge of treatment effects. So I'll go into some more detail on the next slide about this. So this is, there's a certain amount that you need to know in order to be able to make a decision about how to prioritise outcomes, and so and sometimes there are gaps in our knowledge, and this might be a concern because we might not be there might be limits to that are placed on what we know, and this might affect. There might be some uncertainty about whether we're making the right judgment call overall. The next is we've described this as values and circumstances. So, I mean, given that fairness obviously consists in patients being able to make their own choices, but their expertise in their own life also needs to be balanced against clinical expertise. The next is where priorities conflict. So there might be certain tensions. There might be tensions between the weight we give to achieving short versus long-term goals, the weight that we give to palliation of symptoms versus delay of the condition, and also how to prioritise the management of comorbidities, which is obviously a pertinent issue given that many people affected by Alzheimer's disease are older. The next one, the seventh, is which I'll also go into some more detail about in the next slide. So this is communication, autonomy, and coercion. So, given that Alzheimer's disease can impede communication of wishes and preferences, how can we be sure that we're protecting self-determination as the disease progresses? And we've heard in various presentations the need to assume agency rather than the lack of as the disease advances. The eighth is caregiver issues. So, so how we prioritise the needs of caregivers as well as people with Alzheimer's disease, and how do we ensure that there's no confusion between the preferences of the former and the latter? And this might become particularly kind of relevant in the later stages of the condition. And the final one is, as Susanna touched on in her presentation, is the disclosure of risk. So, how do we assess the value of early risk detection given the lack of a disease-modifying treatment, and given the impact, the impact of the knowledge on life, and the uncertainty of progression to the later stages of the condition. So, a quick sort of methodological point. We think that these 9 themes can be kind of grouped into 3 further categories. So, okay. So the importance of it's important to ensure the adequacy of the procedures according to which we allocate resources. And so this is a question about justice. So justifying who should get what and in what quantities. And so, I mean, this is a question, this is a insoluble question in philosophy. Nobody's ever figured it out yet, so it's probably going to continue to rumble on. But philosophical tools derived from understanding the way that different theories of justice compete is going to be important in negotiating these kind of dilemmas. It's also important to identify that the outcomes we're identifying that are important are the right, that we're measuring the right outcomes and the ones that are most meaningful and important to stakeholders. And of course, being able to do this requires involvement with stakeholders, engagement with stakeholders, of people with Alzheimer's disease in particular. And so the tools of social sciences such as interviews, focus groups and surveys are ideal for this, and therefore social science research methods are also invaluable for this kind of work. And the first 2 are relevant for broadly relevant in a healthcare context, but the third is dementia specific, and this is namely the need to mitigate impaired communication of wishes. So, as I've said before, because Alzheimer's disease can impair the ability to clearly convey wishes, there's a risk that prioritisation doesn't properly reflect their preferences. And in summary, I mean, both sets of tools, the philosophical and social scientific ones, are vital here, both for providing the kind of theoretical framework according to which we decide how to weigh the importance of different outcomes, and also for soliciting as possible, as comprehensively as possible, the relevant data about preferences. Okay, so we'll go through these very quickly. Yes, so to the first one highlighted in green, gaps in knowledge of treatment. What counts as a fair prioritisation of outcomes depends partly on what needs to be known to make a prioritisation decision. So, I mean, whether an intervention is or isn't desirable can only be judged according to its outcome. But interventions, especially pharmaceutical ones, might have trade-offs between desirable effects and undesirable side effects. And weighing these is still less straightforward where comorbidities requiring different types of treatment are present. So that's one salient ethical issue. And I mean, despite being the apparent gold standard, RCTs have limitations, which I'm sure we're all aware. So, and I mean, some of these might be that investigation of drug-drug interactions isn't always comprehensive. Data often lacks statistical power, and RCTs determine effectiveness of a single drug for a single problem, but as AD is so heterogeneous, this might not be always optimally helpful. And the likely presence of comorbidities combined with gaps in knowledge of effects can limit the accuracy of prescribed treatment regimes. And also the risk of attrition is high, since the average age of Alzheimer's disease patients is older and comorbidities limit participation. So I'm not going to answer this question or ask for discussion of it now, but it's just something we might think about. So RCTs have gaps which real-world evidence, real-world data might be able to help fill. But the greater volume and more heterogeneous data you have, the more difficult it is to prioritise different particular outcomes, because the amount of outcomes you've got is likely to increase. So, I mean, asking provocatively, we might ask whether this in fact is practically ethically useful in resource allocation decisions. I mean, I think it is, but it's just something to think about. Okay, so this, the second and third groups of concerns, which I'll take as one, communication, autonomy and coercion. So acting according to people's preferences depends on being able to solicit those preferences, but because Alzheimer's disease can impede communication, it might be difficult. It's also important not to assume that that people with dementia can't represent themselves, but the means for doing so become compromised, and this becomes particularly acute later in the disease. And at the end of life, this is particularly important. It's particularly important, given the gravity of what's happening, that the dying person's wishes are understood as explicitly as possible in advance. And given the kind of qualitative content of such wishes, of understanding such wishes and such preferences, real-world evidence and data looks like well suited to helping deliver such a goal. Finally, caregiver issues. So carers are often best placed to represent the interests of people with Alzheimer's disease, but we need to ensure that they're able to do so, and they actually do so. So, I mean, by virtue of having the closest interaction with the people with the disease, carers are probably best placed to interpret their wishes, but is this actually a guarantee? And also, knowing what ought to be done for people with Alzheimer's disease, if their preferences are hard to discern, carries a risk of harm or error. There's some evidence to suggest that carers' evaluations of quality of life is more negative than effective people, but there's no way to verify this. And also, there's some evidence that carers have preference for a rapid decline towards the end, but whether the effective people do share this can also not be verified. So, again, given the kind of really personal nature of preferences at this stage, again, qualitative data, such as the kind that characterises real-world evidence, real-world data looks well suited to this task. And so another discussion question, so given the kind of apparently obvious benefits, what we might ask, I mean, it looks like it's more preferable to more formalised kinds of data, such as RCT data, for providing information about quality of life, because it's better for conveying information about meaning. And it might be effective in most stages of the disease, but in the final stages, it might reduce the issue, but it doesn't resolve it, and so the challenge of whether we really know whether the person's affected wishes are really being acted upon remains. So we might ask that, although real-world evidence, real-world data might shrink the region in which there's a risk of error, it might not eliminate it completely. So we might ask whether it's in fact in reality practically ethically useful for protecting the interests of people in the final stages of the disease. And Right, conclusions. So we concluded that I mean, these just highlight the kind of difficulty, the balance that needs to be struck when trying to allocate resources, and also given the kind of usefulness of a combined philosophical, and ethical, social, scientific approach, we reflect on how the tools of these disciplines can help address challenges posed by resource allocation. I realised that one slide that I didn't include was the one, our recommendations. So I made a note in my hand to remember to state our recommendations. The first one of which, we made two. The first one of which is that, what is it? Is that in a sense, I mean, it looks like what we're trying to achieve is a balance between everybody's preferences. But of course, in a sense, patients are prior. So, and so, I mean, that's maybe not always obvious in, we think, well, we're trying to, make sure that we're being equitable and adjudicating completely even-handedly, but of course, in a sense, the priority of the patient's interest is always at the forefront. So it sounds obvious, but in fact, it's probably worth pointing out. The second one is that given that there's, as we all know, this kind of increasing emphasis on the prevention of Alzheimer's disease, so moving as many people out of risk as possible, a population-level strategy. Despite the obvious benefits of this for the future, I mean, we might ask whether what benefit this has for people who are currently severely affected by the disease, and if there's a choice about how to allocate resources, and more resources are being allocated towards prevention, then there's a risk that, in adopting this kind of aggregate benefit strategy, that we fail to keep in mind the preferences of people who are already affected. So that's an important recommendation, we think. I'll leave it there.